Dr. Amrita Joshi is a self-employed clinical psychologist, psychotherapist and founder of Silence Psychotherapy, established in 2011. Silence Psychotherapy is a feminist, trauma-informed and queer-affirmative space. She is also the co-director of Project Sukoon, which is housed at TES and funded entirely by Mariwala Health Initiative. The vision of this project is to provide psychosocial counseling services to individuals, couples, families with matrimonial litigations and legal settings. She is a doctor of psychology in clinical psychology from University of Hartford. Welcome, Dr. Amrita. Over to you.
I'm really privileged. I'm really honored to be here because I'm looking forward to this enriching dialogue with everyone and also to hear question answers. I think it's just a great space to engage in very, very important discussions. I've been given a key job, which is to kind of moderate this space. So what I'll do is I will do a first round of introductions for everyone, if that's okay, and then we'll jump in with the first panel. So, all right. We have three people presenting here today. The first is Sudarshan. He's an assistant professor in the Department of Humanities and Social Sciences at IIT Palakkad. He's trained as a clinical psychologist, has contributed to critical studies of mental health, calling attention towards nurturing a humane mental health care ecosystem, responsive to alterity, context, and a diverse lived experience. His paper today is going to be about campus counseling centers as cisgendered and heteronormative organizations, examining their invalidation and its implications on the mental health in India. After that, we will have Shruti. Is a queer-affirmative and trauma-informed drama and movement therapist and a stand-up comedian. They specialize in working with queer trans individuals and training healthcare professionals to be queer-affirmative through their uniquely designed embodied experiential play-based workshops. So they'll be talking about their research paper on reimagining embodied healing, centering body-based practices in queer-affirmative spaces. Thank you. Then there's Neha, who is a final year student, currently pursuing an MA in psychology at the University of Delhi. Using a multidisciplinary approach with a focus on the Indian context, she's interested in studying in the complex interplay of cultural and socio-political stressors in relation to individual and community well-being. Neha, your paper is titled Unraveling the Tapestry of Social Reality and Psychological Distress Within a Therapeutic Setting, the Queer Muslim Perspectives. Thank you very much. So with this, the first round, as has been suggested, I feel like if it's okay, I feel like the first round is more like setting the tone. So I would invite each one of you, you have about 5 minutes to speak, after which you know the instructions from there. I invite you all to please elaborate on the lens that you have used to critique the mainstream mental health practices that you're about to present. Sudarshan, would you like to?
No. Thank you so much for the kind introduction. Good afternoon. And I have this paper is actually based on my personal experiences. So to set the tone, I would like to explain some of the background information with which I have come up with this paper. So as a queer person, I have always expected that the mental health field or the psychology disciplines would be more empathetic and compassionate. But when I entered the psychology and even mental health training spaces, including a central government mental health training institution, it was not so welcoming, it was not so compassionate. So I didn't see much compassion around me as we expect out of people who should be empathetic, who should be non-judgmental. So that has always led me to ask a lot of critical questions whenever I met people from many diverse backgrounds, including women, Muslim women, question certain invisibilizations, invalidations, because I myself was discriminated, I was invalidated and invisibilized at mental health institutions, even by senior psychiatry residents, classmates, even teachers. So it was like very difficult. So I moved again to I was not interested to stay back in the mental health. I thought that right, there is a need for an interdisciplinary lens to look at mental health, which is not possible in a very mainstream mental health training institutions like we have NIMHAN, CIP or LGBRIMH or any other training institution, which was very much, reductionistic in nature. So, so this work actually comes from, so I have not seen much difference when I moved, because I had the privilege actually to be at a mainstream mental health institution, also at IITs, to IIT where I did my PhD and now I work. So I didn't see much difference between mental health professionals and engineers, and sometimes I have felt that engineers are much more empathetic and considerate than mental health professionals. So I didn't feel that getting trained in mental health disciplines or having a PhD degree or will make people so empathetic or fit to be a mental health helper or a mental health professional. So this work actually comes from because there was a Google form which was circulated by an education institution asking for with only two options, gender, male, female. So I actually retorted back saying that this is actually something violative of the statutes, even the Transgender Rights Act and the Supreme Court judgment, and please change this form, because there will be staff, faculty members and students who may get violated. It's a kind of, but I didn't get any response, even though I wrote 4 emails to the same, and again the same form was again circulated. So and also I also asked, because many of the public interfaces, the education institutes public mainly the websites, even if you look at the library website, it will see if you don't bring, if he, him, no, it's all his, her, he, him, his, him, only 2 gender binary. So I even wrote back saying that these public interfaces, please change it, because I was part of a library committee, but it has been 2 years, but there is no action on the same thing. So I was thinking about how this language plays out in mental health and how it actually creates a kind of space administrative complex which is very much cisgendered and heteronormative. We can think about the institution, but I moved to the counseling center, which is very much important because it's a mental health counseling center and it is housed in, so I was looking at the IIT's counseling centers, which also have the same kind of language. There is no different language there also. So there is a kind of hand in glove kind of alignment with the majoritarian discourse, what we see in the social, what we see, but legally it has there has been changes, but legally, socially, and morally, these 3 and the side disciplines often come together. So the lens with I look at this issue is critical psychology lens and also a public mental health perspective, because counselors, mostly I interact with students and they often have certain issue. They go to the counselor, but it may be due to very many structural issues, including sexism, heterosexism, but that is not actually taken up. And even language creates reality, and reality is also sometimes could be expressed through language. So I am particularly interested in the interplay of language and how language in mental health or mental health institutions or counseling centers expresses the dominant cultural values, and also looking at the culture of mental health systems, particularly campus counseling centers, only specifically with regard to gender and sexuality.
So just setting a little context about my inquiry. So if I have to sum it up, it's about like how we need to make the embodied practices, the body-based practices more queer-affirmative. And then how do we need to make the queer-affirmative practices, trainings and dialogues more body-centered? Yeah. So for this research purpose, I've used my own lived experiences in an autoethnographic inquiry. So basically I used my own body as a tool to really understand, those moments where I would have felt frozen, I would have felt a lot of discomfort, but did not have like a lot of words to be able to articulate those experiences. Whereas my rich lived experiences might be rich, I would also like to acknowledge the limitation that my practice is set in the metropolitan urban context. So let's just, the first part of the research, which is about like how embodied healing practices need to be made more queer-affirmative. So let's first name a few things, which is that, if we look at the body-based practices, they're dominated by cisgendered upper caste, upper class women. And as a young creative arts therapist, when I stepped into the field, I would try to be, like as femme as I could be. And because I used to think that, that's how creative arts therapists are supposed to look like. There is no mirroring of, queer bodies, of transgender bodies. So how do we engage in body-based work when, there is such a literal invisibilization of our bodies at the first place? Then secondly, even when there are conversations around queerness, around transness, there is this Savarna urge to, really go back to the ancient Hindu texts and locate gender fluidity there. Then the third thing is around, like, a basic level of safety. A baseline of safety is often assumed while working with our clients. So we also need to look back, what are our scripts of feeling? Like when we use words like regulation, grounding, and a very trendy word, self-care. Are these like really, influenced by very heteronormative Western ideas? And when we decontextualize these words, these experiences for our clients, then in a way we are creating like a huge split between the therapy and the outside world. So just to give like a personal anecdote, so I was just going back home from my therapy session in Delhi Metro, and I want to use the public washroom. So I just thought I would give a world a chance this time, and I went to the public washroom in the women's toilet, and the supervisor there started to bang the door really violently, as they thought like a man had entered the women's toilet. So, there's so much of dissonance. Like, although I was coming from my therapy session, experiencing so much of safety in my body, but the forces outside, in the outside world are so, at a very literal level, so violent towards us. So the dysregulation and the hypervigilance that we experience in our bodies, if we don't acknowledge that, how they are such a basic survival tool that we need to carry within us to, go day by day to be able to survive in this society, then, there isn't a lot of meaning behind these words for us. And when we talk about PTSD, trauma-informed approaches, CPTSD, we also need to understand that most often those at the margins, there is no post in our trauma. And it is very continuous for us, it is very unpredictable for us. And in the second part of my discussion, I'll continue to like how then, like body can sort of become this bridge between our inner world and between our outer realities, and how we can use the body itself to make our approaches more queer-affirmative. Yeah, thank you.
So I used an intersectional lens through which I conducted semi-structured interviews with 11 participants from across the country. As a framework, many scholars have attempted to explain how intersectionality critically and analytically dissects multiple social identities that come together at the level of individual experience to lay bare the systems of oppression that are connected at the socio-structural level. The field of psychology has a lot of potential to call for radical structural changes that can improve the well-being of all individuals and to make social justice and equity more important goals. And the intersectional lens can assist in these efforts. So there's a paper that was published in 2005 by Khatija Chandler, and she basically critiqued counseling and psychotherapy in the UK. So she's saying that they have been unable to connect with the marginalized groups there. And this study was based in the UK, but it is very relevant in India as well. So she says that what worsens this issue is that any effort to change the situation from within the discipline is extraordinarily static. So in her opinion, in order to address this pervasive disparity that is occurring, we must first question the concept of neutrality in the therapeutic space. So she argues that there can be no neutral stance because it is often supported, it is often expected that it is basically a tacit support for the status quo and established power dynamics. So this drives away clients who belongs to marginalized groups because you are severing their ties to their actual experiences. So active participation in the combat against structural injustice is necessary for a more connected therapy experience. It is desirable, it's also very much possible to do so. My participants were queer Muslims who have sought therapy for any mental health issues faced, and I basically explored the context of their mental health issues, which includes the relationships with their communities and the kind of mental health challenges that they faced, and we also looked into their experiences in therapy. These questions, particularly in relation to the queer Muslim community in India, has not been explored, that is one thing. But as a student of clinical psychology, I also found it extremely pertinent that we consider how individuals belonging to two socio-politically implicated identities in India, and that too at the intersection of it, navigates therapy. The queer community, as we all know, faces many issues in the country today, with housing, with healthcare, in the workplace, and other equally relevant concerns include the lack of amplification of the needs of rural and working class queer individuals. With regards to the Indian Muslim community, you all may have heard the famous Sachar Committee study from 2006, which has stated that Muslims experience difficulty in obtaining even basic resources like housing, bank credit, and government employment. In addition to this, Indian Muslims are also underrepresented in the administration, court, and police, and this leaves them particularly vulnerable in the face of legislations and policies. So there were mainly three questions that I had which directed this research. The first is, what is the context of mental health distress that affects these individuals? So this includes cultural, religious, and queerness-related factors. So under the first theme that you guys can see in the slide, I looked at how participants tend to have very different kinds of relationships with their communities in relation to their queerness. They talked about the perceived incompatibility of being queer and Muslim at the same time. They also voiced an overarching concern of the Indian Muslim community at present. So this includes that they had an anxiety about being perceived to be violent, or they had difficulties in finding housing, or even being ostracized when they were kids for bringing non-vegetarian items in their tiffins to school, which sounds like a small thing, but it actually does impact you for a long time. The second theme also answers this question. Here, the mental health challenges that come at the intersection of queerness and Islam were highlighted. This includes reference to the intense isolation and alienation that they experienced within both communities, and the resulting conflict of identities as well. The second of the three research questions was, how does this intersection influence the therapeutic experiences of individuals seeking mental health support? So this includes a form of discrimination and this form of stigma and discrimination that they encountered, as well as how these experiences affected their engagement with mental health services. So the rest of the themes that you guys can see give us some insight into this question. Participants spoke of the initial expectations before they sought therapy. They simply wanted a non-judgmental space where they could learn to function more adaptively and explore themselves. In the next theme, participants spoke of prejudicial attitudes that were shown towards them in the therapeutic space, a space that has always had this image of being neutral on paper. So some instances. One example was a participant who said that the therapist told them that they were being radical for fasting during Ramadan, which, if you guys know, is a very basic tenet of Islam. It does not indicate anything radical with negative connotations. Also another instance when a participant was told that CBT and mindfulness could help in making their queerness go away. So this shows us how therapy can be used to maintain a certain status quo by those in power. So another issue is the scarcity of therapeutic resources for transgender individuals, even at prestigious institutes. I'll just take like a bit more. So many stated the fact that there was a lack of therapists who could effectively help them with dealing with gender dysphoria in particular. So on a concluding note, I found it very important to understand the experiences of therapy for these participants while highlighting the ways in which their identities may be heavily implicated in a supposedly value-neutral space and supposedly ahistorical space like therapy. How are the challenges that they face shaped by it, even if it may not immediately appear to do so, and how the therapist's attitude towards these challenges are also shaped by their very own value-laden perspectives.
Thank you so much to all three of you. No, I think you've already given us, like I said, it has set the tone for what we're about to give in. I think I'm realizing the kind of lens with which you have been examining some of these ideas too. We're just wondering in the round 2, maybe if we can focus more on what would you suggest, like, offer any suggestions based on the work that you have done in transforming some of these, because I think you've been looking at most of these mainstream, mental health spaces. And I was wondering if you could give your opinions on what kinds of changes were you hoping for, how would we go about doing that? Your ideas, your thoughts are welcome for the next round. So maybe we'll go in the same order, if that's okay.
So I think with regard to my topic, it's actually it's a work in progress. So I have actually done a content analysis of the websites of 23 IITs, the counseling centers, so where I have found, no employment of no gender inclusive pronouns, no use of words like queer-affirmative, etc. So what I feel is that what changes could be brought, or what transformative change, I think mostly what I have seen mostly in IITs and counseling centers, it is the clinical psychologist who is appointed as the psychological counselor. It comes by many names, counselor, psychologist, psychological counselor, but the eligibility criteria is mostly MPhil in clinical psychology. That is what is set by the institution. So mostly because they are trained mostly in the mainstream mental health disciplines. So I think education and training goes back to the training, and it goes back to the heteronormative cisgendered way of psychiatric training, which is still in vogue. And also recently the National Medical Commission, the Madras High Court criticized the National Medical Commission for bringing back gender identity disorder into some of their, recently, it was only 1 week ago. So such things, so who is producing this language, who is producing the syllabus, the representation, and also I think legal sensitivity is something I think is also, because I was in the panel for recruiting a clinical psychologist for IIT Palakkad, and when I asked about conversion therapy, none of them, that very few, had, 2 of them did not have any idea. And when I asked about sexual orientation and gender identity, there was no answer. And I told the panel that I don't think, and even Madras High Court judgment on banning conversion therapy, Supreme Court judgment 2018, none of these things are actually, known by. So I think lack of legal sensitivity, critical, approach to mental health, that sometimes mental health can also be a legal issue, and intervention need not be mental health, direct mental health intervention, but it could be legal interventions also. So, and also I think mental health professionals should also, I think, move from curing to caring, because care is very much lacking in mainstream systems. And if there is a disorder, find the disorder, even if it is not manageable, cure, target the disease, target the disorder. But caring is limitless. Curing is not possible many times. Even cancer, palliative care. I was talking to some of the, like Dr. M.R. Rajagopal, who actually brought up this palliative care movement in Kerala. So he also says, like, doctors always try to cure, but Hippocratic oath itself, if it is followed, it says that, cure sometimes, care always. But these things, because it is taught in, like as a footnote in mental health training, even health, definition of health itself is like very broad. But when it comes to MBBS and training or clinical psychology training, we only look at the personality and the brain. Neuropsychology becomes the fashionable subject, and the other social psychology or the caste, all this never come into the syllabus, and even if it comes, it comes as a footnote. So, but I think in Global South, it's important. So I think it's as a change in that sense, I think it will be very helpful. Because even one of the students once asked me, like in a beta class, what is the point in studying psychology? Because it's a faltu subject, because we know everything about brain, we have technology, we have fMRI scans, so why should, this is a waste of time? So it's a very genuine question, so it actually shakes the fundamentals, shakes the foundation of the discipline. So it's a very good question. So I said, can you categorize, if you can you think of, loving somebody? Then he said, yes. Hating somebody, yes. Sometimes it is like you hate the person and love the person at the same time. So can fMRI scan tell you, like, no, I hate this person at this level and not. So I think it's very important, but psychology, foregrounds itself as fMRI led movement. So I think it should change and it should actually become more grounded. That is what I think is more important. Thanks.
Yeah, so sort of building up from what Sudarshan has mentioned, like, just having a degree in psychology doesn't ensure empathy, compassion. And when we look at it from a body-based lens, we can, begin to see that most of our trainings are very disembodied. Like a lot of academia trying to understand, the mental health of the marginalized, it's so away from the body. Like, for example, like the conversation around pronouns, like people will be, sitting and dissecting that, how it's a new trend, or is it about the politics, or is it like a movement of margins? But it's like, then nobody's really interested in, what's the bodily experience of a 5-year-old trans kid when for the first time in their English book, they're reading the concept of pronouns and they're feeling disoriented in that moment. So we really need to look at like, what is that, interests us when we are studying as therapists. Then, why body? What's the need to bring body in the picture? Is because these oppressive structures that we are carrying within us are not existing at an intellectual or a cognitive level. Because if they did, then, then just being aware about things would have been enough. We would not have been, perpetuating those systems at such a real way in our daily lives. Then the first line of discomfort or distress that we experience lies in the body. Even, when we didn't have the language to say out, to sit in this panel and really structure our thoughts in this manner, we knew what's happening, right? Then the first form of protest as well, it exists within our body. Our bodies have been protesting. And now looking from the lens of the mental health of queer and transgender individuals, many a times we do not have the accessibility for the vocabulary to express who we are. And even if we do, there isn't a lot of safety to, really claim the space to own up to those identities. But still, our bodies, really hold who we are. They do not depend upon how we identify ourselves as. Now coming to, like its applicability in the therapy sessions. So, no matter like how knowledgeable we are, still in the therapy sessions, whenever we are working with the mental health of margins, there is going to be a lot of discomfort. There are going to be moments of feeling threatened. There are going to be moments where we feel a lot of helplessness. And now the traditional systems, they tell us that, as therapists, we are not supposed to feel so vulnerable in our body. But if we look at from the body-based lens, like these moments of feeling discomfort, threat can really become our navigating points to really understand, the larger structures of the society, to really understand our clients, to really understand ourselves as well. And I think as a society, like when we talk about placing the distress outside of the body of the queer individual, as a society we are so dissociated from queerness, and then हमें बोला जाता है कि हम dissociated हैं. And maybe as a society collectively we have gender dysphoria. That is why we need to create these binaries in the first place, to make the concept of gender so digestible for our own selves. Okay. Thanks for that. Okay, I forgot. Okay, so just like the last point from my side, like again, like field of creative arts therapies in its formal sense is new in India, but like what Shweta was also saying in the panel yesterday, that the art forms have always existed around us. There have been, group rituals, peer counseling that exists in the communities. So as therapists, to be, really open towards that idea. And then, like how they present in social media, how movement therapy looks like, these big flowy movements, it's not like that. It's really about the breath. It's really about the body. And as therapists, like just the simple thing around like how are we breathing with queerness, what does the word queer do to our body? because the queer phobia is really internalized. It's very deep. We experience it. And it's okay to accept it. It's okay to, really breathe with this internalized queer phobia so that, like we can explore that shakiness in our own self-reflective practice before we step into the clinic spaces. And so it's okay, like if you're even experiencing it in the clinic spaces, if you're an open therapist, we are very accommodating that way. Yeah.
So this idea has been reiterated over the past few panels, yesterday and today as well. But it's important that when you're dealing with clients belonging to a marginalized population, that you don't try to fix the issue without looking into the root cause of the issue, the structural causes of it. So I'll give another example. One of the participants had told me about an instance where one of their uncles had received a notice during the initial rollout of the CAA. So they were told to put together their registrations, documents, and so on. And there was obviously a lot of fear and a lot of panic involved, and this participant wanted to talk about it with their therapist. And when they told this to the therapist responded by saying, why are you so worried? It's not like you're Bangladeshi or anything anyway, right? And the participant was obviously very hurt by this remark, like what would you say to something like that? So the participant tried to explain that, it's not about whether I am Bangladeshi or not, regardless of the fact, this is something that could very easily be used against me. There is no logic that needs to be followed for it to be used against me. And so apart from being very dismissive, the therapist's lack of acknowledgement of the sheer injustice of the situation can come across as implicitly pinning the blame of the client's justified fear onto the client's own pattern of thought. They're saying that it's something like, what is wrong here is your thought process, not what is happening outside. So as Indians, it's not uncommon to hear people talking about, a pluralistic society, a diverse cultures, and so on. But what does it say about us if we cannot even do the bare minimum to accommodate this diversity? It is important to approach what we don't know from a place of curiosity rather than judgment, and this is particularly true within the mental health disciplines. At the same time, it's also important to not have an overly individualistic perspective. So you all, in the poster presentations as well, you all may have seen the term minority stress theory. So I'm going to be talking about that here as well. So it has been influential in guiding research on sexual and gender minority health and well-being in the social sciences, particularly under psychology, sociology, public health, and social welfare. So Mayer had articulated this the first time in 2003, and he wanted to understand the social, psychological, and structural causes accounting for mental health inequalities among sexual minority populations. So there are two kinds of stressors that he talked about. One is the stressors, one of the kinds of stressors that originates from people and institutions and impacts the queer person. The second is the internalized stigma of the individual's own experiences. Concealing their identities can be protective in certain circumstances, but at the same time it also cuts you off from the social support that you could be having, the community that you could be having. So collectively, these minority stressors can constitute the excess stress burden that often is experienced by this population. Studying the situation of queer Muslim individuals, specifically in the Indian context, utilizing this theory can also give us some insight into the mental health inequalities present. Because they have a lot of research that has said that the kind of trauma that has been experienced by queer Muslims specifically is very severe in comparison to their counterparts from other faiths. So there have been uniquely high rates of depression and religious trauma, along with particularly low rates of familial acceptance. So interdisciplinary interactions can also help in providing a holistic perspective of a client, particularly within hospital environments as well. This includes working closely with other mental health professionals. So for example, when you facilitate group sessions with clients with similar problems and issues can come together, and this can be co-facilitated with, say, social workers. And this gives a space for opinions to be understood and validated, while at the same time kind of evening out that power dynamic that arises in one-on-one sessions with the therapists, particularly if your client happens to come from a marginalized section of society. At the end of the day, if you aren't from this exact intersection, you may have some difficulty in understanding the exact nature of the lived experience of this post-Hindu professionals. And when you're leaving out marginalized groups from the creation of knowledge, the production of knowledge, it also impacts who it goes to, who it helps. And in a paper from 2012 as well, Jadhav has talked about how there's a need to decolonize existing theories of mental health in the Indian context, because it lacks space for culture-specific suffering. Ultimately, as mental health professionals and students in mental health disciplines, we must understand that systems of oppression are not absolutely unchangeable. It is also important that even within the field of psychology, we all also have a role to play in it as well. You can either uphold it or you can fight against it. And so-called neutral therapy spaces are often antithetical to fighting against it. You also need to be very clear about your stance as well, and collaborating with organizations that align with your goals can help. Thank you.
Thank you. Thank you to all three of you. If it's okay, shall we now, we'll take a couple of questions and then...
Therapy is always thought of as this neutral, apolitical space. But we know that the personal is political and it does enter the therapy room often. And we have been speaking about how to, kind of make space for clients who come from marginalized backgrounds. But what happens when we have a client who is, for example, being Islamophobic or being queerphobic or saying caste things in the therapy session? How do we as a therapist deal with that? Because what I have been taught is that if you have such strong views about these things, don't deal with the client at all. Just like pass them on to somebody else who can deal with that. But I, as a person who comes from a position of privilege on many axes, feel a responsibility to kind of address that within the therapy session as well. So I'd like to know from the panelists how I can handle that.
So Jay, I teach MA Psychology course here at KC College. I mean, one of the things about CBT and mindfulness practice being recommended to people who come in regarding concerns about queer identities resonates so much with me. I mean, CBT has become the go-to thing for everything. CBT, REBT, especially in Bombay. I don't know. I remember distinctly during Viva session, I was asking, treatments that one can go through when one is experiencing psychosis. CBT. Challenge the delusion. And it was an existential crisis for me as a faculty that what has been happening, in class. So I feel there is some sort of in critique of the discipline also, which comes from interdisciplinary lenses. And I have, been actively participating in sociology conferences and, discussions on gender and sexuality. Of course, usually not held by psychology departments because departments themselves all, operate in silos. Bombay may also departments barely know each other, to be very honest. What is... I feel that the reason why there's a disconnect from psychologists is because the language of critique, often does not take into consideration what is the current language of discourse within the field of psychology. Often I have felt that even when I'm discussing, in class, someone talked about multiculturalism today in the earlier panel, kind of connecting with what's happening, because I feel a lot of critique comes from critique of psychoanalysis, for example, of psychotherapy. I have barely heard of any critiques of behavioral therapy, CBT, REBT, gestalt therapy, which are actually now more upcoming and dominant therapy perspectives as far as I'm seeing around myself. Any suggestions from the panel in terms of, have you all heard of any discussions which kind of are using this language of discourse within the discipline to open the gates and helps people in the discipline connect to the critiques coming from outside of discipline, because they have, of course, looked at other social processes with a more minute lens, right? Any suggestions from you all, anything that you've heard of that I would like to know about, okay? And anything from your experience of doing research, of course, if you're doing research which includes psychology as a part of the disciplinary lens, I'm sure one question would have been in terms of quantitative karu kya, qual karu kya, and often in psychology, quantitative is something that is heavily given, the status, ki quant research is the best. My experience with quant research has been a little different. But again, my primary question is ki suggestions based on connecting, using disciplinary jargon, disciplinary discourse. Any suggestions that you all have?
I run a postgraduate diploma in data science for social impact, and I'll speak from that vantage point. So enumeration is one of the most important things for any group to receive recognition and also to be able to access government-related facilities or recognition. So I feel that when big surveys like National Family and Health Surveys they have systematically erased, gender identity, in the sense that they have either minimized it or used a very narrow definition, and in the last 2-3 years they have completely dropped questions related to gender, especially queer community is not represented, and I am disabled myself, and I was shocked and appalled to see that they have even dropped disability as a category in National Health Family Survey, which is a very important survey to even recognize and acknowledge people and enumerate and bring them into enumeration. So when we look at national institutes like at IIT Delhi or IIT Palakkad, they also have to follow the same agenda that is set by MHRD, right? And it's not like you cannot isolate politics from healthcare, because they're all intertwined. So my question is, will this ever be able to change? And if the change has to occur, what kind of bottoms-up approach we need to take so that these people get an identity, get recognized, and get enumerated, and be part of the community, right? Because if you're not represented in any data today, you don't exist in the society. Yeah, we exist physically, we don't exist as an identity.
Throughout the day today, we've been talking about showing openness, curiosity when we are sitting with a client. I'm a psychotherapist, so I'm referring client from the marginalized community. My question is for everybody, for the panel, that how do we balance that? Because we are talking also about not putting the burden on them to educate us. So what would that balance be like, where you're expressive of the curiosity, the openness to listen to their stories, while also balancing not putting the burden on them to educate us about it? So what would that balance look like?
I intern at one of the government hospitals here, and the way that I see it is people come in with a diagnosis looking for medicine to so quote unquote fix their depression for decades on end, and continue to do so, whereas counseling is something that's always seen as the peripheral extra thing that they can do to work. So even in like the holy book of DSM, as we know, how sorry. Okay, so stop meandering. So my question is, how do I get a client to believe that counseling is also as necessary as the meds that they are having, and this is not like an assistance to the meds, and probably as important as the meds, and no discounting any doctors that are here though. But how do I build that with my client, knowing 100% that they are that they have a lot of affinity towards the medicines because they show immediate impact? Thank you.
Yeah, I've been seeing that research in mental health, or in general our master's thesis, is just really a waste of time. And and I would even go so far to say that most of the professors in these very premium esteemed colleges really discourage us from taking up any topic even little bit close to anything going into the field of politics or intersection or diversity or inclusion. And I see like even, and then further, even if certain professor is encouraging of that work, there is a lot more problems when it comes to the publication of that work. And if there is no research, we don't have anything to work on, and we don't have anything to include in therapy because there is no evidence-based anything to include in therapy. So how do we go about it further? What is the future in Indian research context, and how do we even think about doing any inclusive work when it comes to research, which is very important for therapeutic spaces?
And to hers, because even if some professor allows us to take a topic that is remotely political or relates to marginalized identities, there's this need to not be emotional about that topic. And I feel that if there is no space for emotion in research, in psychology research, then where else, right? So,
if you belong to a marginalized community and then you take up this topic, there's even more shutdown from their side that, oh, no, you are too close to the topic, so you'll have to work on objectivity. And so I would like you to maybe address how we can maybe open our professors' minds up a little bit more.
Hi, my name is Sanket Gala. I'm a therapist myself, and I'm also a disabled person. My question was for Sudarshan sir. You have studied, you are studying about how counseling centers are in the institutes, and you have you are analyzing how is it for LGBTQ plus community, and where you did mention that the counselors don't have information about it. Have you did you get a chance to also read something about the disability aspect? Because it does so happen that even in our curriculums that we are not taught about disabilities. And if we are taught, it's mainly about, say, ADHD, autism, say, social anxiety at max. But there are a lot of disabilities. There are around 21 disabilities which are mentioned in the law. And how do then the therapists working in those institutions help the children or help the students who are there in the institution itself with also the other adversities or other challenges which are there in the academics?
Recognize that most of the times the psychologists, the understanding about disability is also very, very peripheral, because it's mostly about physical disability, and if a person becomes physically disabled, the person will have psychological issues, and you need to give counseling, and the person will have depression, anxiety. So this becomes almost always the kind of understanding. So according to the PWD Act, we have, I think it's 21 if I'm not wrong, disabilities, and it's also an evolving concept. So definitely the institutions are not disability inclusive. Where I am coming from, still it's a new institution, still even the students have asked for further arrangements for people who are not only physically disabled but for other disabilities, for example Braille system in the library, etc., etc. And also I think it is not about understanding one disability as a category. I think the understanding should be how do we provide equal opportunities to people who want certain kind of accommodation. I think that it should be at that level where maybe, for example, the chairs that we see is mostly that foldable chair will be right-handed. It's designed for right-handed people, but there will be people who may be left-handed and they may not find a left-handed chair, and how the institution is actually, at least through language, maybe through counseling cell, if they can say that we are also seeking inputs on how to include people with the differences, or people who are who need certain accommodations. So even using the word differently abled itself is now questioned in disability studies and all, because ability is again taken as something you don't have that ability, but you have ability in some other sector. So your problem is you are not abled like me in that sense, so you have to look after that, but we will provide you some inputs to make you differently strong. So definitely I think disability is important, but in this particular paper I have not actually looked at the intersection. I definitely understand the need to actually make it a work in progress. So disability itself is something which needs to be, and that disability competency, for example, even in medical professionals and even psychology professionals. So actually I am teaching a course, clinical psychology and disabilities, to actually foreground the way in which disability, just like people from LGBT community and gender minorities have been erased from psychology, not represented. Disability is also the same. One of my PhD students is working on disability. So I hope I have answered your question. Maybe we can talk later.
Yeah.
So when coming to the first question, I think it was how can we deal with a client who happens to be maybe transphobic or Islamophobic. So I think it's a very difficult question to answer, I think, for me. I feel that I take Emmanuel Levinas, who is a philosopher, who says that alterity is a fundamental human condition. So everybody is different. Even identical twins are different. So people may have a different, it's not that I am not biased. To actually acknowledge the fact that nobody is completely empathetic is something that I think psychologists don't never, agree. Like I am empathetic. I have built rapport. I have seen in thesis, like I built rapport with the patient. Even it is very common in psychiatric setting. But in 1 hour you are supposed to diagnose, you have to provide psychotherapy guidelines, everything in 1 hour, and you have established rapport, you have understood mental state, you have understood mental state, history, sexual history, occupation history, everything in 1 hour, and rapport is also established. So I think to go beyond that and recognize the fact that I don't know you, and I'm ignorant about many things, and you are also very different, and people can have different viewpoints, and when a person becomes transphobic, actually I think allowing them to understand the reason, to introspect how they have become, because it's taken for granted. Like they may have never met a person who is a trans or who is a queer or who is an Islamic, who is practicing Islam. But it is through the discourse, so at least to understand the politics of experience. Why I am transphobic is that my experience of being transphobic itself is something that can be questioned through that session or in that conversation, only until and unless the person is so, as I mentioned, I have built rapport, is comfortable enough to share their innate, mental state. I think it is not possible. So I think we should allow room to become different and to have ideas. But how do they carry that idea? When did they carry? When did they start becoming transphobic? Because people change, right? I have seen many people who said, "Oh, sir, I have earlier I had a lot of about when I was a student, when I teaching, I had a lot of aversion towards trans people. When I go in the trains, I used to hug my mother and parents but after attending our course, sexuality and mental health, I feel that they are also human beings. So I think that listening to stories, maybe not direct contact, imagined contact. That is what classes do, right? I sometimes it's not possible to take them to all the different field work or to the field and get them have a meeting directly. But imagine contact, or implied contact, movies, etc. I think it helps. So people do change. That is what I wanted, because there are so many questions. I think I will limit.
So is it okay if the others respond to this same question so that we finish the thread here? But I loved what you said about to understand the politics of their experience. Such curiosity with which you are approaching that as well.
So I think around queer phobia, as a queer therapist, I can say that it has to be handled very sensitively, like especially with my experiences with teenager boys. Most often than not, like they are themselves during that time exploring their own gender and sexuality. So I think similarly I would try to create more space for the phobia itself so that they can explore their own relationship with both the aspects.
Thank you. Now, is it okay if we take the next set of questions, which was, some of them had similar ideas, which was, the language of critique, which especially the psych disciplines not kind of dialoguing with others. Do you want to answer those?
So I think like in queer culture, when we talk about chosen families, I think we should also talk about chosen education systems. And most often than not, they are mostly outside of like the universities that we have studied. So there is a lot of power in the lived experiences. There is a lot of power in the emotional research as well. And like moving beyond our own traditional ideas of also, where we want to learn from, I think we can also see that, there is a lot to learn from people around us, from our friend circle coming from different backgrounds, and like, you know, there are spaces. So first create the spaces of solidarity so that we ourselves find a language to how to express, and then maybe, you know, counter those professors that like a bit level up. So that's how I have approached it. At some spaces, there has been a lot of space for vulnerability, like with my creative arts therapist colleagues, there has been a lot of space for uncomfortable conversations, for me to share that, you know, during that moment I felt like this in my body. But there are spaces where I have to be very, you know, straightforward and very academic. I don't bring my vulnerabilities over there.
Okay, so one thing I want to say is that I am in my final semester of my master's course as well, so I fully understand what you meant by I mean, both of the people who talked about, you know, like, firstly, you shouldn't have too much passion, too much emotion and stuff like that. But this study that I have done, I did it in my previous semester actually. And I'm part of the committee as well. So I was a little afraid that what if the therapist pushes this back, you know, like, oh, this is such a very specific population. And like, even if you look within the field of psychology, like at least in the spaces that I have occupied, they treat queerness as like a novelty, as at least in research, like whether they're prejudiced or not is like another thing entirely, but they are very interested in including it under research. But the moment something related to Muslims come in, the interest is gone, the interest is fully gone. I have observed this multiple times, and at least in this case, I was lucky. I actually found this one professor, I was actually lucky in this sense. But another thing I think that you can utilize in this case is the case of epistemic privilege. You can say, I mean, you said that you are part of the, if you're part of the marginalized group especially, you can say, like, epistemic privilege in very simple terms is that you understand that you are marginalized and you understand the processes through which you are marginalized. So you can say that, you know, like, oh, I have this very unique insight that helps me to talk about this community. And along with that, if it's a marginalized community, it's probably also underexplored in research. That's another topic that you can bring up. I always say that. I'm like, yeah, this has not been explored as much. So it's always there in my research. So yeah, and yeah, and then we can also, I had mentioned this in one of my answers as well, marginalized people have to be included in knowledge production, in knowledge creation, only then it impacts, it reaches these people as well. So, yeah, I think it's very important.
So I think there is a book also called Cognitive Behavior Tsunami, which was written in 2019 or so, which actually talks about because everyone, even if I ask BTech fresh students, they know what do you understand by psychotherapy, immediately everyone knows about cognitive behavior therapies. It's like given, equated, like psychology equated with cognitive behavior therapy, and it has a lot to do with information processing approach, which is in, and because it came after the, you know, revolution, like computer revolution, and this chat bot, all kinds of, like, recently. So I think it's also important to open up the, you know, spectrum of available other modalities in psychology, not only this individualistic modality which is dominant, which is why it is dominant, because psychology promotes it, syllabus promotes it, and many a times, even in MPhil clinical psychology, even psychiatry, I remember, it's mostly the CBT which is taught to the, you know, the psychiatry residents by the clinical psychology department, and mostly clinical psychology department also deal with only CBT, and other forms of therapy models are footnoted. It is like, you know, it's there, like, you know, you can, if you want to read, you, mostly the exams, everything will be mostly concentrating on the CBT model. And so I think it is also coming from that individualistic understanding of mental health, the culture of mental health practice, where the system's perspective is not taken into, you know, account. And even there is a family therapy, for example, psychiatric social workers mostly deal with family therapy, but I'm not saying that, I'm not blaming, but because it's more of a social thing, right? Family becomes a social thing, but cognitive behavior therapy becomes more, you know, objective. You know, you have results, you have certain charts to show the improvement. So it is also because of the, you know, scientific credence that psychology gets, you know, gains through, you know, producing and reproducing this kind of a knowledge, which I think needs to be challenged. And, you know, more avenues should be opened for exposure. So I think it should come from, you know, the knowledge production. I think such centers like MHI is doing that itself, like, counter this, even this conference is opening up as, opening up to counter narratives and different discourses. I think, and also about the language of critique, which I think even there are many, that's what, we are not exposed. There is a epistemic privilege, as you mentioned.
Yeah.
It's also, there is a politics of knowledge production also in mental health, because it's not that there is no critical perspectives in mental health. We are not exposed to it in the mainstream mental health training discourse, because why is why there is no QACP in MHANS or in CIP or in LGBRIMH, right? So knowledge production, like as a course, there is diploma in community psychiatry. You can see the fellowship in so many disciplines in MHANS if you take that prospectus, right? But, so there is a, for example, there is critical psychology, which is established in US and UK. There are MSc and there are courses which are being taught. Even in Kerala, University of Calicut has a course in MSc called Critical Psychology. I was also surprised when I met one candidate. She said, I have done a course in Critical Psychology. I don't talk much. I did not take any course because she has done more than me, because I didn't do that even in my clinical psychology. I didn't even know about who is Foucault, Michel Foucault, before I went to IIT Hyderabad for my liberal arts PhD program. So even this kind of liberation psychology, for example, Martin Horo, Latin American, and even psychiatry, like the kind of racism, the post-colonial, decolonialization, I forget the name of the psychiatrist who is involved, Frantz Fanon. Fanon, it's a figure in social sciences. He's a psychiatrist. But even psychiatrists and mental health professionals don't read Frantz Fanon, who is a key figure in decolonization, not only in mental health, but people from cultural studies. When I was a panel member, that professor was asking she's from cultural studies, was asking my candidate regarding Frantz Fanon, and she was not aware, and she has come up with a proposal to do a project on decolonizing psychology. So this actually points out to the politics of knowledge production and also there's a lot of user survivor accounts. I think Bhargavi Davar, you mentioned, is a user survivor account from mental health in India. Reshma Veliyappan's book, My Life as a Schizophrenist. Pratiksha Sharma, who has written about barriers to recovery from psychosis, recently 2022 release. She opens up, she actually inaugurates the field of mad studies in South Asia. But we are not exposed because our psychology system actually restricts, it actually censors certain things, and that's what I think, because there is a lot of research in critical psychiatry, for example, critical psychology, liberation psychology, psychological humanities. Recently they talk about psychological humanities. So I think there is a need of a breathing kind of psychology, which is which is tied to people's emotions, people's stories, which I think some of you mentioned. Because earlier students used to say that cognitive science, there are some cognitive science PhDs in IIT Gandhinagar. Cognitive science everybody knows, cognitive science lab. But even now psychologists are also rethinking critical science. Why not cognitive affective science lab? Because cognitive science, we are very much towards cognition, but emotion and cognition is so much related, but we deny. That actually seeps into practice also. Like emotion is not, when I cry, it's not something like who cries. A person who is a psychiatrist, if they cry or a psychologist cries, you should be distant from personally, personal professional life should be distant. These are all discourses that we are not told and retold by the mental health systems and which is, I think it is very historic.
Yeah, so I just want to add on, just to give a student's perspective. Students are definitely questioning CBT. That is definitely a conversation that's going on. I won't say it's predominant yet, but the conversation is definitely happening. I remember the first time we were taught about CBT as well. After each therapy type, they give us pros and cons. The pros were there, but the cons were so long. They were these kinds of people can't have it, that kind of people can't have it, these kinds of people. Then the question is, who can have it then? And it's a very, very thin layer of society that can actually benefit from it. But yeah, the conversations about that have been happening. And to build on what my co-panelist has talked about as well, Frantz Fanon is such a key figure, very instrumental, but we are not really taught about him at all. That too, he has given so many anti-colonial perspectives, from the perspectives of the colonized in Algeria. And I did not even know that he was a psychiatrist. I did not even know he was in the mental health discipline until I was in higher education. I mean, despite being in the field of psychology for such a long time. And yeah, and there's something that one of the panelists from yesterday, Christy, had talked about in her panel. She said that education now, the education system is a colonizer's apparatus. It's a, yeah, it's like that. And that shows, you know, like we were in a formerly colonized country, and yet this is the situation. Yeah, curiosity but not burden. So this was actually something that some of my participants had talked about, so I want to just like quickly fill that in. So the thing is, it's important to not keep on asking like, what is that, what is that? It's important to ask the question of more like, what does this mean to you, rather than what is that? Because there are certain things that we should be knowing. Like there's some basic information that these participants as well had expected to know. And I think, okay, I'll give an example just to illustrate what I'm trying to say. It may be confusing. So there was a participant of mine who is AFAB, assigned female at birth, but he identifies as a transmask person. So there is this tension amongst their families that, you know, like, oh, you'll have to wear the hijab at one point. But this person feels that, you know, wearing the hijab gives them gender dysphoria. And they don't know how to kind of like communicate this. But at the same time, so they want to communicate this to a therapist. You know, there's a lot of complexity here. Like, it's not that they find the hijab oppressive in a political, historical sense. They just, it is just in terms of gender dysphoria. So they had a lot of you know, concern about bringing that up to the therapist. Is the therapist going to judge them? Is the therapist going to be very spontaneously dismissive and say like, oh, you must be feeling so oppressed? And yeah, so it's important to ask like, what does it mean to you, not what it is, because that is something that you'll have to work on beforehand.
But I think, thank you for adding every bit of what you said. I think I fully agree about the manualized storm that CBT has taken over. It is manualized, it's also marketed really well, there is no doubt about that. But no, I'm realizing that there's such a common theme in the kind of questions also that were being raised in how you are, you know, you've been saying. So I realized that, I mean, I've been a therapist for some time now, and I've understood that, yeah, therapy spaces are supposed to be safe, healing, holding, all of it, and yet also quite transformative in their experience. So I think one thing I know for fact, I think there's no healing unless there's safety in that space. That much is, you know, also clear. So the queering of our therapy itself is not just for any, you know, whether it's academic campuses we are talking about, whether it's private work, whether it's community work that we are talking about. There's many ways in which we are also visibilizing and affirming the identities of especially those on the margins. So I know all of you have what you've done really. I think as I was listening, not just through your presentation, but I was hearing your responses to the questions as well. And I realized that you've really invited us to critically almost examine these almost everyday practices that we do in sessions, you know, and I think you've asked us to really examine the power, the privilege that we hold, you know, in that session. But you've also, what you've done is you've offered suggestions for what to do in that moment, so that how does one create that safe space even, so that it's safe, it's liberating, how do we dismantle some of that power? You know, and Shruti, what you said is so true, because emotional experiences are not just, I don't know, they're not just ideas at all, but there are so many ways in which we are holding it, storing it in our bodies, they're visceral almost. And I loved what you said about that because they hold, and ultimately those are also transformative experiences for us, I think, when that changes in our bodies somehow. So I think Sudarshan, when you said that, you know, it's almost like the counseling center statement, you know, when they're querying a particular space, that it's a therapist ideology, it's a stance, all of you pointed that out, it's a stance that we clearly are also taking. Neha, when you also spoke about that, that's exactly how I was listening to it as well, that I love this part that you said, that it's a whole space for you don't, the job is not to inform us about it, but is to hold space with that curious lens. Yeah, knowledge creation is not exactly the part over there, but I love the reframe that you did in that moment. What does it mean to you? I think that's something I'm definitely taking back with me. And as I was listening, I realized what we were just talking about it here is really the crux of what so much of they used to call this culturally sensitive, counseling. I think so much of what we spoke about it sounds exactly like that. And I'm realizing that institutes that hold power, but also therapists who are in that space, I think through this session, you've almost been inviting everybody here who has been either in that position already or is about to be in that position to examine that same power, that privilege. And when therapists do that, it's not linear. I know it's not very neat, it's not very clean, it can be super messy sometimes, but it's also an ongoing exercise, right? It's something that one does every time, but I've known that when we are able to do that for ourselves, this kind of unpacking that we are talking about, I think we hold so much ability to create hope and build some really, really beautiful, connections with people. And I really hope that, that's definitely something I'm taking back from our conversations today. So thank you very much to the panelists also, and those lovely questions. I know we have missed a few and we're sorry about that, but I didn't quite expect so many questions. So if you have, I'm sure we'll all be loitering around to ask more questions. But thank you so much.